officially welcome.
Thank you
to
very much.
you. It's a topic that I think was high time we addressed, or that you addressed for us. We've had a series of talks, haven't we, from the perspective of surgery and surgical treatments and other aspects of, if you like, the epidemiology of pancreatitis, but we've never yet had anybody talking to us about medical management. So you're extra welcome, because it's just what we need to hear. I think within our audience, as I was saying to you earlier, we have plenty of people with long-term care issues, and I guess the medical angle is particularly relevant in those cases. So over to you, and thank you very much for coming.
Thank you very much. Thank you very much. I think, obviously, you all know Mr. Charnley, and I work very closely with Mr. Charnley. David, tell me you've heard Dr. Opong. He's one of my colleagues. He's given you a talk in the past, and essentially, Dr. Opong and I do the same thing. I more on the endoscopic side, but over the last couple of years, we've realized that obviously there's more to the pancreas than just putting the scope down and doing ERCPs and other sort of things. And that's where I started taking interest into the medical management. But there are a lot of attention being paid into the medical management of chronic pancreatitis and ways in which we can actually avoid invasive surgery. That's the whole idea, because those of you who have had surgery would realize it is major surgery, and it's not easy. It's not easy, trying to make your mind and preparing yourself for the surgery. That itself is tough, but the recovery after surgery is even tougher. I take it that before I sort of go on to the talk, I've spoken to David already. Most of you have had some form of pancreatitis, acute or chronic. Am I right in saying that? Yeah. And roughly, what period would it be? So, Deb, you had yours almost...
Best times, almost 8 years ago.
8 years, yes. And would that be normal?
No, I was 7 when
You
we
were-
started.
Oh, is it?
No,
So you're
really
on the
surgery.
surgery track. Oh, right, okay.
Because we have a number of people who have had a hereditary problem.
Right, okay.
So that's an early
I started when I was 6.
Were you? Oh, right. Okay. Now that's interesting to know, because the reason being, I think, the reason for asking that question is, by and large, if you tell people if somebody's got pancreatitis, it's a knee-jerk reaction for people who've not had it to say it's alcohol. And that's not true. Well, it's true in the sense that it is the most common cause, but there are a significant proportion of people out there who have pancreatitis which is probably not related to alcohol. And therefore the management slightly differs, because alcohol-induced acute pancreatitis, you take the offending agent away, that solves the problem. But what about the ones who have hereditary pancreatitis? There we are trying our best to make sure that the disease does not progress. We haven't probably got to that stage where we can say we can halt the progression of disease. And obviously there's a lot of work going on, and I'm sure it's just a matter of time where novel therapies will come through, which will address these problems. So please pardon me if my talk is very basic, because I'm giving it for the first time. I didn't want to include too much information, but just enough information, and not too much medical jargon. David kindly mentioned the email. I'm more than happy to take questions, but I'm happy to be interrupted during the talk. I think it's better that way, because I would rather it be interactive, because it's the first time that I'm presenting to such a forum. I would like to know what you feel and what your views are. And sometimes, if I give a half-an-hour talk, which sometimes can be very boring, you might forget. You might think about a question halfway through, and then you might forget it. So please interrupt me. I really don't mind. So without much ado, yes, I am part of the hepatobiliary pancreatic unit, which involves surgeons like Mr. Charnley, Mr. White, and Mr. French, but also my colleague, Dr. Opong, the radiologists who form a very, very important part in the decision making in treating patients with pancreatitis, and obviously all the other paraclinical, they're called paraclinical, but they do form an important part of the team, the dietitian, the physiotherapist, the intensivist, all these form part of a unit. And it has expanded quite a bit over the years. You probably have heard Mr. White and Mr. French being appointed as surgeons. Myself, I was an additional physician who was appointed in the trust. There are more intensivists with special interest in pancreatitis who manage the condition. And that's why I think initially I used to think, oh, pancreatitis is not very good. But having worked here and having worked with Mr. Chani and his team and reading more and more about it, you know, there's a lot we can do. There really is a lot we can do. But I guess David was telling me that the care has to be concentrated in centres who are used to managing these conditions. And Mr. Chani is again doing a lot of study into the care that is provided across the region and how best to manage the condition. Now, you probably, I think you've heard a lot about pancreatitis. What I'm going to do, just to make the talk a little more interesting, I'll give you a bit of background about chronic pancreatitis. So I'm not going to talk about acute pancreatitis, I'm going to talk about chronic pancreatitis, because I think that's what the acute pancreatitis affects you in the acute stage, but the long-term sequelae happens only in a small group of patients. But it's a chronic, those who have repeated attacks of pancreatitis and develop chronic pancreatitis are the ones which are the most difficult to manage. So I'll give you a background as to why chronic pancreatitis develops. You probably have had that talk before, okay?
Not as a specific talk.
Okay, okay, that's good, because I think then I can tell you what the disease is all about. It's not as simple and straightforward. It's extremely complex. And then I will try and focus on the management. And as David suggested during our email exchanges, I'll concentrate on nutrition and pain management, which would you all agree is probably the most difficult part of the problem. So chronic pancreatitis, what is it? Now, it is a heterogeneous and complex, irreversible disease. Now that is the most important thing. Once you get to the diagnosis of chronic pancreatitis, the pancreas doesn't have the ability, like the liver, to regenerate. And therefore, once you get to that stage, then what you're looking at is, one, if you can try and stop the progression of the disease, and secondly, to see if you can improve the quality of life. How do you get to chronic pancreatitis? The classic model is the hereditary pancreatitis model, where you have repeated attacks of acute pancreatitis, which causes sort of little bit of damage to the pancreas, and then over a period of time, which can take a long time. It can take up to 30 years to actually develop into chronic pancreatitis. And it is these little damages that, in conditions like familial pancreatitis, that the researchers are trying to concentrate on. How can we treat it? Alcohol-induced pancreatitis, obviously, if you stop consuming alcohol, it not only stops and delays the progression, but it also can help the pancreas recover a little bit. So that's what happens. It's over a period of time, and this acute recurrent. Recurrent means it's happening again and again. And in patients with hereditary pancreatitis, this may not necessarily mean admission into hospital. It might just mean, oh, I've had a little bit of a niggle, and these niggles, you know, happen repeatedly over a period of time, and then suddenly you're investigated, and then you come to this diagnosis. You know, you might be 7-6. How was your pancreatitis actually diagnosed? Was it?
I had an abscess, and I had an emergency surgery.
Emergency surgery. Oh, right. Okay.
My daughter, she was 15, so I was about like 44 or something like that. She was like poorly for about 6 months, treating her for constipation.
Yes.
And when they finally did a scan on her and found the pancreas, and I'd already told him that my dad had died of pancreatitis.
Right.
So he said, can we do a scan and everything will find So I didn't find out till I was 44.
Right. Did you not have any symptoms till
Oh,
then?
yes.
You're right. Okay.
When I was 18, a doctor in the RBI said, you've got a nervous stomach, you'll grow out of it.
Oh, right, okay.
And then just from self-diagnosis, I thought, every time I have a drink, I'm not well, so I'm just going to stop drinking.
Yeah.
So I had a good spell, late 20s, early 30s,
Right,
because
okay.
I didn't drink.
Sure. Okay, that's interesting. So I think that's what it is. It starts as a small duct disease. Now, as you know, the pancreas is an organ which has got tubes in it, and the organ actually feeds all the juices into the tubes. It goes out in the bowel, and that's what digests the food. So the actual effect actually starts from the smaller branches in the pancreas, and then involves the bigger branches. And sometimes the presentation of these two conditions can be quite different. So you could have small duct disease, which is early chronic pancreatitis, where you won't see anything on the scans, but you'll be in a lot of pain. And as you mentioned, you'll be labelled as somebody as having a nervous stomach because you can't find anything. To getting to the end stage chronic pancreatitis, where you've got all the florid signs of calcification, damage to the pancreas, the diabetes, etc., etc. As I said, please interrupt me if you have any questions, anything. I mean, don't feel shy. I think even if you don't understand any of the medical jargon, please do let me know. Obviously, all of you know you probably know the clinical sequelae, and there are two main consequences of chronic pancreatitis. One is exocrine insufficiency. This essentially is a reduction in the secretion of the digestive enzymes. Now, pancreas is an extremely important organ for digestion, as you all know. And in chronic pancreatitis, that's what's affected. The enzymes, the digestive enzymes there, are not secreted because of various reasons which I'll come to. And because they're not secreted, all the food that's going into the small bowel doesn't get digested. Because it doesn't get digested, it doesn't get absorbed. And because it doesn't get absorbed, you develop symptoms of diarrhea. You're not absorbing all the nutrients. You start losing weight. So that's one of the sequelae of chronic pancreatitis. Pancreas also is obviously, as you probably are aware, that plays a very important function in regulation of blood glucose levels, and that is why we develop diabetes, because they're not able to control the sugar. Insulin secretion reduces, so all the food that is supposed to be controlled by the insulin, there isn't enough around in the bloodstream, and therefore you develop diabetes. But I think all of you will agree that one of the most difficult, frustrating, and sometimes debilitating symptom of chronic pancreatitis is pain. And it's part of the exocrine endocrine insufficiency, but I would rate it as a completely different entity, because the management of this particular problem is much more difficult than the other two. So what I'll do probably is just go quickly through the management of exocrine insufficiency, where there aren't enough digestive enzymes. Remember, you get to that stage only when nearly 90% of the pancreas is damaged. So in a way, it's similar to the liver, because the liver doesn't start failing unless 80% of the liver is damaged. And the same applies for the pancreas. So there has to be significant damage to the pancreas to actually cause this problem. And many of the patients that we see now don't really have the symptoms of loose stools, unable to flush the stools away. We do get patients with incredible weight loss, but we don't see that much. Is it something? Do you? No.
Yeah, I was always thin.
Yeah, right. Okay. And did you have you had any of you had diarrhea?
Not diarrhea, but definitely floating on the top, but I just thought it was normal.
Yes. No. I think most people would, I think, because the dietary variations can also change the consistency of the stool. So you would just assume that it is part of normal bowel behavior. Obviously, dietary advice is important, and I've looked a lot into which particular type of diet do chronic pancreatitis patients need to be on. And frankly speaking, there isn't a particular type of diet. You can be on a normal, healthy diet, provided you're on adequate pancreatic enzyme therapy, which again I'll talk in detail, and vitamin supplement. So as long as you replace that, you will be...
Do come in and join us.
Okay.
Very sorry.
You'll be such an... Do you want to close that door as well? Just with Alan when you were lying about and that?
That would be helpful.
Yeah, it's okay.
Thank you.
Sorry for just letting out. Manu Nayar, I'm one of the consultants who works at the Freeman, and sort of I'm more of a physician rather than a surgeon, and I'm just talking about the sort of medical management of chronic pancreatitis. So as I was saying about the diet, and I've spoken to the dietitians here about it, and they again said you don't really have to go on a special diet. But the difficult thing is trying to balance taking adequate enzyme therapy with the diet. And what she did tell me that one of the most important things in diet really is to reduce the amount of fat intake. And the reason for that is that the pancreas secretes enzymes such as lipase and protease, which actually digest the fat. Now, if you eat more fat, you need more lipase. And pancreatic enzyme therapy will give you that replacement, but not like a native pancreas would in normal individuals. And if you're adhering to all the diet-related, if you're adhering to the diet and you still think, oh, I'm not getting anywhere here, that's where you should start thinking that is there anything else going on? And I'm sure while some of you might have been followed up in hospital, this is the sort of kind of protocol we follow. We expect, we would expect that chronic pancreatitis, especially on the background of familial pancreatitis, might progress, but a sudden change in symptoms, either weight loss or not able to eat, you should start thinking of other infections like bacterial overgrowth and giardia. So the reason being, these are very easy to treat. But these are very easy to treat with simple antibiotics.
I'm going to take you at your word. Can I just interrupt for a moment?
Yes, sure.
I think we probably all take Creon, and Creon is the supplement that you've just been talking about.
That's right.
Have you any particular advice? Because about the taking of Creon, I think it's an area that we, in talking to others, we tend to be under-advised about.
Right.
Clinically, when you go for your outpatient thing, you're told here's your prescription, but how to take it, in what sort of, in what ways. Somebody did suggest to me, for example, that you take it as a sort of sandwich in the course of a meal. But do you have any light to shed on that?
I've got just a slide. I'll just move forward a bit. I was good. Pancreatic enzymes and chronic pancreatitis. Now, it's a very relevant question. But to answer your question of how, when, how much to take it, we need to really understand how it works. The three main enzymes that are secreted by the pancreas are protease, lipase, and amylase. When we talk about Creon, 10,000, 25,000, 40,000, it's the unit of lipase that's present in the Creon. And the reason for that is you need a very high dose of lipase just to sort of digest the fat that you're taking, because you can go on a no-fat diet, but that's not good for the body. The body needs minimum amount of fat, and it's roughly sort of in patients with chronic pancreatitis we advise between 50 to 75 grams of fat. Just to give you, when I say 75 grams of fat, for example, a packet of crisps has somewhere between 6 to 10 grams of fat. But then if you divide it under different diets, if you have a cake or chocolate, so the amount of fat actually varies from diet to diet. So that's fine. But it has also got protease and amylase, most of the pancreatic Creon and other preparation. You talked about the sandwich of taking Creon during the meal. Now, Creon is best taken either during the meal, just before the meal, preferably not before the meal, during the meal and after the meal. And the reason for that is if you try to take creon an hour before the meal, the creon will just go into the stomach, the acid in the stomach will just inactivate the creon. So you're taking high amounts of creon, say you're taking creon 40,000, but part of it gets inactivated. So by the time it goes from the stomach into the duodenum or the beginning of the small bowel, where the digestion actually takes place, you don't have much enzymes remaining. So it gets inactivated. And that's the whole theory behind taking it with the meal or just after the meal. Okay? You can get around it because it's the acid that inactivates the creon. You can have antacids before the meal, or you can take antacids on a regular basis just to reduce the level of acid so that it doesn't inactivate the creon that much. Other way of doing is enteric-coated tablets. Have you tried enteric-coated tablets before? No. Again, it's just a way of preventing that inactivation that takes place in the stomach, or the breakdown of creon that takes place in the stomach, so that you get the maximum dose of the enzymes with your food. Other thing is, if you eat food that is too hot, that again can affect creon. So there are lots of factors because of which creon may not do the job that it's supposed to do. This is something, obviously, it's new to me. Has anybody had this problem with creon? Irritation of the perioral skin or mouth?
Yes.
You have, right.
The geographic tongue.
Yes, right, okay.
I didn't know that's the first time I've heard anybody say that it might be related to either creon use or the condition it's treating.
I must say I haven't personally known of any patient that has developed this sort of irritation of the perioral skin, and it happens if you chew the creon in the mouth and it hangs around in the mouth for longer. But I guess most people wouldn't chew the creon; they would just swallow it down. So I guess that's one of the reasons we don't see it that often. Somebody else had a question to ask when David was asking a question. Yeah.
My sister she's got chronic pancreatitis, well, we've been familiar, and she gets an irritated tongue. Could it be from taking creon? If she just swallows it whole?
Probably not. Again, because my experience in this particular problem is so limited, the only other way where she might find a difference is to try the enteric-coated creon.
Right.
Which will be less likely. Maybe she's sensitive, and as soon as she puts the creon tablet in, whatever is there in the creon tablet just causes the local reaction just before she swallows it. So it might be worth trying the enteric-coated tablets to see if that actually prevents that problem. If it doesn't, then
it happens when she's taken a creon.
Always happens when
No, I don't know. It just starts every now and again, doesn't it? I'll get at the watch out and see if it's
I think
creon.
if it's happening whenever she takes creon, it might be worth going for the enteric-coated tablet, because then there's no contact of the contents of the creon with the lining of the mouth, and that might prevent it. So how much dose is required? Now, I guess that's probably another question that David asked is, how much creon do we need to take? And how much creon do people take? What's 25. And how many would you, sorry, go on.
4.
You take the 40, okay. And how many would you have with the meal?
1.
I take 2.
You take 2?
1. I take 2. I do the 10,000.
Right, okay. It is definitely true. There are 3 basic principles. 1, the creon dose has to be adjusted with the size of the meal. But then, what size of meal relates with creon, we don't know. So many of the times, the dose of the creon is adjusted with the symptoms, i.e., if you have too loose a stool, then you take enough creon so that the consistency improves. If you're losing too much weight, that again suggests that probably you're not absorbing all the nutrients that you need to. But the basic principle is that, and I'll tell you why we are slowly moving on to 40,000 units of creon, is that to digest food, what the body normally would secrete is anywhere between 30 to 40,000 units of lipase, probably 10 or 15,000 of protease and a bit of amylase. So that's the normal amount that the pancreas, that a normal pancreas would secrete to digest the food. So that's nearly 40,000. Now, as I said, the unit that I mentioned is always the lipase, so I'll focus on that. So that's the amount of lipase that's required. Now, we are artificially giving enzymes. Some of it gets deactivated, some of it is lost. So by the time it gets to the small bowel, say if you're taking 2 of 25,000, nobody knows, but this is a guess that you might not be getting the full 50,000. You might be getting something like 30,000. So you might be falling short a little bit. But again, that's not a problem. That's not a problem because you can adjust the dose. You can go up to 2, 3 tablets of 25,000 if you need to. And there has been a couple of good studies suggesting that the higher the dose, the better. Better in the sense it helps with not only digestion of the food, but it may also prevent progression of the disease to a certain extent. How does it prevent progression of the disease? Okay, I'll show that slide later on. The way it prevents the progression of disease is that it gives rest to the already damaged pancreas. Because even though the pancreas is damaged, the body's reflexes work in such a way, as soon as the food goes down and after a couple of hours, the pancreas gets stimulated, it makes an attempt to secrete the enzymes, but it can't because it doesn't have any. And that's where the pain and everything, all those symptoms start coming in and causing problems. And therefore, if you give a higher dose, you're kind of, the negative feedback of the body works in such a way, the body realizes, oh, we've got enough enzymes here, the pancreas doesn't need to be stimulated, so let's just give it a rest. And the artificial enzymes that you have will help with the digestion of the food.
Can you take 2 lunch? I just tend to take 125 no matter what I'm eating, and everything's fine. But I do sometimes think, if I'm just having a little snack, maybe, because I do have some 10,000 ones, maybe I should just be taking 10,000, but would it be doing any harm taking 25?
No. I think that's the important thing, but it's very easy for me to say that, okay, you take 3 tablets with every meal, but you don't really need to, and you have to cater, you have to adjust the dose as per your symptoms. If your pain is under control, you're not having loose motions, you're not losing weight, then what you're doing is right, both in terms of the diet you're on and the amount of pancreatic enzymes that you're taking. So basically, coming back to the question of how much to take, to a large extent it varies from patient to patient. I have patients who've got exocrine insufficiency who are just on 2, maybe 3 tablets with every meal. But then I've got other patients who don't have deficiency of enzyme or are not diabetic, but they are on 80,000, so 240,000 with each meal. But the reason for that is pain. They seem to have more pain than the other symptoms. The role of 40,000 now has also been investigated in patients with pancreatic cancer. They say in pancreatic cancer, where the pancreatic duct is blocked, again, enzymes help in improving the symptoms, both in patients waiting for surgery and the unfortunate patient who cannot have surgery. So it's becoming quite a big area of interest. The actual, what is the minimum dose of creon that you need? And the reason people have started taking interest is because of this very reason, that the amount of creon that you take, all of it doesn't get absorbed, or all of it is not involved in the digestion of food. I put this up just to complicate matters, just to look at the different types of pancreatic enzyme therapy that's available out in the market. Is everybody here, or those who are actually on creon, are on pancreatic enzyme supplement, are all of you on creon? Or do you take different preparations, all of you?
My dad takes Resign.
Your
My dad
your
takes
dad.
Resign.
All right, okay. Now, I have known some patients saying that Nutrizyme is better tolerated than Creon. I don't know why. It may be to do with the coating and stuff like that, it is better tolerated. But I have one patient who's not been able to tolerate Creon, and I've tried to put them on Nutrizyme, but this only happened a couple of months back, so I haven't really seen him back again, and he hasn't rung me back to say that he's suddenly much worse. But there are a small group of patients who may not tolerate Creon. So this is just to put up a slide to let you know that obviously there are a couple of other preparations around in the market which you can try, and which some patients might tolerate better. For example, your sister, you mentioned about the perioral eating. Might be, I mean, if she might try your diet Nutrizyme and see if that works. It may work, and she may never have those. If obviously it's that causing the problem rather than something else. Does that answer your question?
Yeah, well, it does, and I don't want to monopolise this bit, but I also think that there is a problem with foods that have a cellulose coating, like I don't know, peppers or aubergines or even tomato skins, which I think I find difficulty in digesting now, which I didn't before. Is that related to the amount of enzyme or artificial enzyme you ingest?
No, this is just pure guesswork.
Right.
But what I would say is that cellulose is obviously not something that's digested by the human body.
Right.
And to a large extent, all the fibers, cellulose, etc., they get broken down, but they don't really get absorbed.
No.
And if they don't get absorbed, then it's less likely that pancreatic enzymes might be affecting either their digestion or their absorption.
Well, I tend to avoid those skins because otherwise they go straight through.
Sure. That is a problem, because I was going to come to that, because if you imagine, if you have long-term sequelae of pancreatitis, you have your bowel transit is hastened anyway, and it's a pancreatic enzyme therapy that kind of keeps it under control. But if you take foods which are high in fiber or foods which contain substances that is not absorbed with the body, it's going to go through. It's great for patients who are constipated and all that, but for us, it's probably not the best. And I think you're doing the right thing by just sort of cutting back on those type of foods. But it's unlikely that the pancreatic enzymes are going to affect their digestion anyway. I'll look into it. But,
Thank you, that's fine. That's very helpful.
I'm not aware of that. Got a little bit out of sync. It's okay, I don't mind. I think the diabetes, I'm not going to spend too much time. Any one of you diabetics here? Okay.
Yeah.
Has it been difficult? Has it been difficult?
Incorporate it with control.
Can't
The
get it.
diabetes goes up and down all the time.
Does it? Control.
Took a while.
Okay. Because are you under a special diabetic consultant? Right. Okay. And do you understand sometimes why it is difficult to do? Because again, it brings back the whole same analogy of the pancreatic enzymes. When you've got a normal pancreas secreting normal insulin, then all the insulin that goes into the bloodstream starts working on the food. But when you're giving insulin separately, the use insulin or antidiabetic? And the oral antidiabetic.
Tablets as well.
And
Try and get it.
Get under control. Okay. And does the diabetologist, because this is another thing, sometimes the diabetes that you have may not be related to the chronic pancreatitis, and it may be a combination of both things. Does the diabetologist believe that's the case, or he thinks it's related to
the
the...
record in your pancreas is actually just now and again putting insulin in.
Right.
Because my pancreas is 3/4 destroyed.
Sure. Okay. And that's one of the reasons, the difficulty in controlling blood sugar in chronic pancreatitis, because you never know how much insulin is coming in from the pancreas, and you want to avoid hypoglycemia, and therefore sometimes you might err on the side of caution because, as you must have been told, it's better to be a little bit high rather than go too low.
That can go from high to low within minutes.
Is it?
Yeah.
No, that is interesting, and it is a problem. It is a problem controlling. It's almost, diabetes and chronic pancreatitis is similar to diabetes in the very young. You know, the very young people who develop diabetes in their teens or in the younger age group, by the time they get to their early 20s, very, very difficult to control. Again, same reason, you never know how much insulin is being secreted. Probably won't spend too much time on that. We talked about nutrition. I think this is probably the kind of standard advice you give: have smaller meals, restrict the fat intake to that much, avoid trigger foods. Similar to probably what you mentioned about cellulose containing or coating containing foods. Has anybody else, do they have to sort of alter their diet in any way so that you don't too much spicy food?
Spicy.
No,
Yeah,
it's not.
spicy.
Yeah. That's what I've learned from the patients that I see, that they're really not able to tolerate spicy food.
Oh, no.
So yeah, avoid trigger foods if you can. And again, it's obviously catered to individual patients. And medium chain fatty acids. Now, this was fashionable, I think, 2 or 3 years back. Because they are much easier fats to digest as compared to normal fat. But then there have been a few studies which have said that they're probably not that helpful. Now, it's quite a nightmare, it's quite a job trying to find food that contain medium chain fatty acids. Did any of you try to? No. I think we probably tend to give
That's
that.
definitely not on the back of packets, is it?
No, it's not, exactly. Not the many colours and information that we have, yes. I think we tend to give that to patients who actually get admitted into hospital for feeding. You know, there are some, I don't know if you have got admitted into hospital just for feeding purposes, just to increase the weight and improve your nutrition. No, that's good. That's good, because there are, I've again spoken. Freeman's actually the regional nutrition centre, and they run what's known as parental nutrition or home parental nutrition, where they give nutrition directly into the veins. But as part of the service, they also provide nutrition through tube feeding. And when I spoke to the dietitian, the senior dietitian who was involved with these cases, she said that we don't really have many patients on the registry with chronic pancreatitis requiring home feeding. So that's good in a way, because that just tells us that obviously those who have it are taking the right precautions, taking the enzymes, being careful about what they eat, so that they don't develop more symptoms.
So what kind of foods have the medium fatty acid?
That's a tricky question. I think it's mostly in formulated food, in the things like Ensure and Procal, which are sort of regulated what do you say? Build-up drinks, basically, and oh, do they? Right, okay. Have you tried Procal, which doesn't have a quantity of Ensure, but it's got all the nutrition. So, and they come in really small cups. You know, Ensure comes in 100 mils. And have you tried Procal now?
Tried.
Oh, right, okay. Okay. Just going through.
Just go straight through.
Right. Okay. But other foods don't go straight through. Other foods wouldn't do that. It's just the building blocks. Yeah.
I used to take Enlive, and then now I don't. But my doctor says that I didn't need it anymore. But it wasn't Mr. Charlie or anybody advises. So should I still be taking it, really?
are you, I'll have to
Maybe
ask
weight's
a question
pretty
for your
stable.
question, but
Yeah.
otherwise are you sort of having on a healthy diet, you're not losing weight, you're
Pretty
otherwise
stable,
alright,
really.
really
yeah.
stable, then you don't need it.
No.
It's for people who, in spite of doing everything, are continuing to lose weight, are very thin, have a low body mass index. They are the ones who actually need the build-up.
It was mainly after my surgery, whilst I was building myself back up, then I think that's when
That's right.
prevention.
Yeah. So I think if you're fine and you're feeling well in yourself, feeling as strong as you can, then you don't need the build-up drinks. But just bear that in mind if you go through a phase of a few weeks where your tummy's niggling a bit. And
I just liked it there sometimes for, like, if I didn't feel like having a meal or like at that time where
Yes.
I could
exactly.
take that
That's
option
right.
really.
Yes, because it's a waxing and waning condition, right? And you'll have your, I hope you have good days most of the time, but you might have your bad days, and that's where you can supplement it with these build-up drinks, because at least it'll give you the nutrition,
Yeah.
and then you don't have to worry about trying to eat well and try to get all the food that you need to eat.
I don't know if you're going to cover it later on, but what's the best thing to do if you are going through a bout of pain?
Well, okay, yeah. Well,
If you're covering it later, that's fine.
yeah, I've got a separate section on pain. You asked me the question. And the reason I put it up separately, because this is actually a talk. Mr. Charlie asked me to give a talk on pain and chronic pancreatitis a few months back, because there were a few pancreatic surgeons who were a select group of around 10 senior registrars and consultants who had come for a sort of day meeting. And then he told me to talk about pain and chronic pancreatitis. And I thought, my God, I'll be the only physician in the whole room trying to convince these guys that, the answer to pain management is not surgery. And it was a difficult part, but it made me realize that it's much more complex. It's not just, oh, you've got chronic pancreatitis, you've got pain, and that's the end of it. The classic type of pain, or pancreas type pain, is epigastric, that's just below the rib cage here, which tends to radiate to the back. That's a classic book, textbook description of pancreas type pain. But that only occurs in a quarter of the patient. So 3/4 of the patient don't have this classic pain. And that's what makes it confusing, because then you start thinking, oh, is there another reason for the pain? It probably isn't chronic pancreatitis, but no, it most likely is. And pain can occur in more than 90% of the patients. So the most common symptom of chronic pancreatitis is pain. But the interesting thing is there are two different types of pain in the evolution of the disease. Type A pain is at the onset, where you have peaks of pain, but in between those peaks you have pain-free interval, and which can be for lots of long periods of time. And these are the group of individuals who will actually get admitted into hospital because the pain is so severe. Or, less likely, in patients who have a very high tolerance for pain might elect just to stay at home, just not eat or drink anything, let the pain settle down with painkillers, and then they'll have a period of having no pain at all. So that's at the onset of the disease. But as time goes on, the pain is more continuous. So you can see this graph here, it doesn't really touch the baseline. So these are individuals who are in a little bit of pain constantly, but they will again have peaks. And this is most of the times related to complications of chronic pancreatitis, cysts and stones in the pancreatic duct, etc. But one of the most interesting things I learned about pain in chronic pancreatitis is the burnout phenomenon. Have you heard about that? Because there are a small group of chronic pancreatitis patients in whom the pain just disappears over a period of time. And nobody knows why that happens and in which group of individuals that happens. So it's completely unpredictable. So I can't say if somebody has got pain and then whether that particular individual over a period of time won't have any pain. It's great to tell somebody like you, okay, you look like an individual who's not going to have pain in 10 years, but it's very difficult, it's unpredictable. I put this slide up, it's some clinical jargon. The reason for putting this up is pain in chronic pancreatitis is a very complex problem. And the reason it's a complex problem is there are too many things going on at the same time which causes pain in chronic pancreatitis. The first one is obviously ductal mechanism, i.e. the pancreatic duct. There's blockages, there are complications that prevents the duct from working normally, i.e. secreting the pancreatic enzymes, secreting the juices, secreting the insulin. So it's mainly defective plumbing, essentially. That is, that the duct, the tube is blocked, and therefore you have to find ways to actually relieve that blockage, to actually relieve the pain. So that could be sort of all sorts of complications that can be associated with chronic pancreatitis. But again, it makes you, the more you read into this, you realize it's not that straightforward, because even if you have all this and you have pain, there are other individuals who may not have all this but still have pain. So the ductal anatomy, so that is the structure of the duct of the pancreas, does not correlate with the pain. This is not bad news, really. It just tells you that there's no one reason for pain in chronic pancreatitis. And then it comes to, about nerves. It has been definitely established that patients with chronic pancreatitis actually have enlarged nerves, and they are much more sensitive. And therefore, any stimulus to this, to the nerve, would cause more pain in patients with chronic pancreatitis as compared to somebody who does not have chronic pancreatitis. I'll come to that. To the next slide to illustrate that. So that's normal sensitivity. So you give a painful stimulus, say to the skin or any other part of the body, it provides a strong input into the brain, and then you perceive pain. You give a gentle touch to the pain fibers. The brain really ignores it. It's a gentle touch. It's not a painful pain. But what happens in chronic pancreatitis is that gentle touch can also increase the input when you give a painful stimuli, but even if you have a gentle touch, it still stimulates the brain. So you can imagine that, even a little bit of, have anybody of you had trigeminal neuralgia, or, and you must have gone through the phase, even if you touch your face with your finger, a light touch, and it just accentuates the pain. Similar sort of mechanism works in chronic pancreatitis. And that's what was established in a lot of studies. But you also have to remember there are we get so involved in treating patients, we put them on lots of strong painkillers, etc. They also have side effects, and they also can cause the pain. And that's why it becomes very, very difficult to manage pain in chronic pancreatitis. Apart from all the medical things that I mentioned, there's a significant psychological and psychosomatic element to the pain. And apart from the structural problems, the psychological problems can again accentuate the pain. So when we're trying to treat pain in chronic pancreatitis, we're not looking for trying to get completely rid of the pain. That to a large extent is an unrealistic goal for patients who actually have severe pain with chronic pancreatitis. So the aim is to prevent recurrent attacks, slow down the progression of the disease if we can, and as I mentioned, aim for reduction rather than amelioration of the pain. All easy said than done, but as we've just seen that it is challenging. It is very challenging because there are so many mechanisms involved. We don't know in a particular individual, is it the nerves, is it the hypersensitivity, is it a problem with the plumbing, as I mentioned. So it is difficult, and therefore it really has to be a patient-centered approach. So the approach to pain management has to be for that particular individual. You can't have a common protocol for everybody. That's the kind of take-home message I would give about pain in chronic pancreatitis. So you have to individualize the patient care. We probably won't go through this. We've already talked about this. Am I okay for time, David? You
Another few minutes.
getting fed up with you going on talking? I think we all know, and those of you who had pain related to chronic pancreatitis would agree that painkillers remain the mainstay of treatment. Again, it's a top-up approach is always good. So start with a milder painkiller first, and then we tend to move on. We can add things on the way, and they're effective if two things are used together. Many patients will quickly move on to this. Now, can I ask, how many of you are on sort of strong opiates like that? You are, right, okay. How are you finding it? Are you? It's
No.
difficult. It must be difficult with all the side effects.
Yes, I get the severe constipation. Obviously, you take the lactulose and the Senator, and sort of like dietary, try and eat plenty of fibre, but the pain's not.
Pain's
not
continual.
gone.
It is continuing.
He's had pain for nearly 2 3/4 years now.
Right, okay.
She never gets relief from it.
No, sure.
She's just gone on to oxycodone. But he's
Oh,
found
actually.
we were on Oromorph and what was it?
MST.
MST.
Morphine sulfate.
Just did nothing. So they're trying that, and I think he's going to increase the dosages on
the oxycodone. Okay. And this is, again, a common problem. This is a common problem, and it's the side effects which sometimes is very debilitating. And it's something you have to be extremely careful how we treat it. I'll give you a few tips, because again, I've spoken to other teams in the pain management service here who will be quite keen to help patients who have specifically pain related to chronic pancreatitis. So as I said, narcotic dependency. This is obviously that's not the case with you, but there are a lot of patients out there who are dependent on opiates. So they would actually come into hospital just to have the opiates. And it's not because they really want it, but they're so dependent on it. They just want anything to get relief from the pain. But unfortunately, again, if you look at literature, because of the complexity of the problem, there's poor data on the efficacy of all these different things that we give patients. There are some additional treatments that you can give. We talked about pancreatic enzyme therapy for deficiency of enzymes, but what about pancreatic enzyme therapy in patients who actually have pain? Again, there was a big meta-analysis is a way of looking at all the papers out there, all the literature out there, which have used pancreatic enzymes for treatment of pain. And unfortunately, they have shown that it's not effective. Probably helpful in early disease. I think it's my policy, and I think I've had a chat with Mr. Charnley. We tend to give a trial for around 6 to 8 weeks with very high dose creon to see if that helps. If it doesn't help, if it doesn't make any difference at the end of 6 weeks, then we stop it. Don't ask me why just 6 weeks. We just randomly pick a time period to see if that helps. And there are other forms of treatment available. Again, not very effective. Have you heard of nerve blocks for pain? Yeah. The idea of giving nerve block is to actually prevent the transmission of the pain impulses from the pancreas onto the brain. So that if the brain doesn't perceive the stimulus, then you won't feel the pain. So that's the rationale and the logic behind it. And again, it's reserved for patients with limited treatment options. For example, as you mentioned, you're having problems with controlling it with opiates. There are 3 ways of doing it. You could do it radiologically, where they do a CT scan, look at the nerve where it has to be injected. You can open it up, and I think Mr. Charnley has done quite a few in the past. And we have developed, or rather, there's a new method, which is endoscopic ultrasound-guided injection of the nerves. Now, you can see the problems and the advantages of all these 3 techniques: CT-guided, it's costly, it requires a lot of expertise. Surgical one, you can imagine it's theatre time, it can become quite a costly affair. But the endoscopic ultrasound is quite safe and equally effective. And myself and Dr. Rapong, we do quite a lot of endoscopic ultrasound, 600 to 700 biliary and pancreatic ultrasounds a year. And we are quite, I mean, we have done probably 2 or 3, not a lot, but this is what we tend to do. That's the endoscope, that's the ultrasound probe, that's the nerve fiber which is wrapped around this artery known as the celiac artery. Now, this collection of nerves is what transmits the impulses from the tummy to the brain. So what you do is you put a little needle into that nerve ending, which is located around here, and you inject steroid or you inject alcohol, absolute alcohol. If you inject steroid, it's known as a block. If you inject alcohol, it's known as complete disruption of the nerve, and it's called neurolysis. But I think there's a problem with that, because if you completely destroy the nerve, that itself has its own implications. Is it effective? Very recent paper which says that it is probably effective. Effective in the sense we're not aiming again for complete amelioration of the pain. What we're aiming is, can we reduce the dose of the opiates? Can we relieve the pain? Can we increase the duration of the attacks or reduce the frequency of the attacks? Ideally, it's useful in patients over 45 years and who have not had any previous surgery. Endoscopic therapies, I guess Dr. Opong must have spoken to you with you in the past. Lots of things that we tend to do here. This is a big cyst where we can drain it through the stomach, so you don't need surgery. So after draining, it looks from that to that. It still looks a little bit messy, but you can imagine such a big collection. In the old days, till 10 years back, they were all having surgery. Now you don't need surgery. You can do it endoscopically. There are narrowings in the pancreatic duct, which can be easily treated by the stent that has been placed in the duct, again, which can help, can relieve some of the symptoms. I'm not saying it's the all-in-one treatment, but these are options that are available apart from surgery. As I said, I spoke to the pain management service at the RBI, and what they have suggested is in patients who actually who are finding pain in chronic pancreatitis debilitating, they'll be quite happy to take a GP or a hospital clinician referral, so either from our unit or somewhere else. And the good thing is they do have a holistic approach, so they do quite a bit, and they'll cater the management for the individual patient. I mentioned about future therapies, and lots of work going on, and I'm quite interested in that, because obviously that's moving leaps and bounds over the last few years since the mapping of the human genome, and that might be quite a good treatment. So I think I should conclude that chronic pancreatitis is a complex and heterogeneous disease. The most important thing is to establish, diagnose earlier on in the disease so that you can cater the treatment to that individual patient. Nutrition is extremely important in the management protocol, and as I mentioned, good balanced diet, good creon supplements and vitamin supplements if you need to. Pain remains an extremely difficult problem to control, and the treatment really has to cater to the individual patient. Apart from surgery, there are other therapies that are available, which again can help with some of the symptoms, but may not be the only treatment. Again, it has to be a multidisciplinary approach. Thank you very much for your patience. Can I answer your question about pain in chronic pancreatitis?
Yeah. Would it help if you do stop eating? Would that help your pain?
It may. Okay. The other important thing about pain is that the pain could be either because the whole of the pancreas is affected and there's a lot of calcification, and in those cases it's difficult to know what the real cause of the pain is. Or it could be some obstruction to the pancreatic duct or the bile duct where the treatment is different. There the treatment is try and relieve the blockage. So it might involve surgery, endoscopic therapy, drainage of cysts, etc. If that is not the case, and the pain is really related to diffuse damage to the pancreas, stopping eating will, but then it's a balance. Because at some stage you'll have to start eating. And in those cases, the best thing is to increase the dose of creon to see if that helps you.
I'll just get a bout of pain probably once every couple of years, 3 years or something at the minute. And it might last a week.
Right.
So sort of cutting down on eating would be an option. If it would help with pain to stop quicker.
Have you tried that before?
No.
No. Okay. What have you tended to do then when you actually have those
Pop painkillers.
painkillers? What about creon? Have you tried increasing the dose of creon?
I don't know. I don't actually take creon.
Oh, do you not?
No.
Oh, that's okay.
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 I don't take anything at the minute because I find it makes us constipated and I end up suffering more pain because of that than taking creon.
No, I think, yes, I guess you're right. It's a difficult situation because I can't, in your situation where it's happening once every couple of years, creon's not really justified. What's probably happening in those once in every couple of years is you're probably having an attack of pancreatitis. What's known as a subclinical attack, where it's not severe enough for you to go into hospital, but it's probably happening, and then as the inflammation goes down, everything's fine, and you have your painkillers. But you're right, you're absolutely right. It might be an option just to reduce your oral intake, just to give a bit of rest to the pancreas. And that's what it is, you just rest the pancreas.
I'd hardly like to stop this. I had this real sense that Dr. Manu Nayar has today really engaged with individual patient needs and patient concerns. Right behind me a moment ago was patient-centered approach, and I think that's been exemplified in your talk. You very helpfully addressed concerns that have been shared, and thank you for sharing them with our speaker. But I think such a clear and helpful response has been given that we ought really to thank you in the usual way.
It's really nice meeting all of you, and hopefully we'll meet up again.
Well, thank you. Yes, and well,
you don't need to.
I don't make a joke, but not
yes, not in hospital. Yeah,
No.
Well, thank you. I think there's another cup of tea and a raffle to draw. So if we'd like to go back to where we were before, we'll conclude the evening that way. Thank you very much.